Hello, CAM followers. Sorry for being a few minutes late. We're just having a little bit of a technical, just because Giliola is so advanced with technology. Everybody else's technology can't keep up with it. So I just want to introduce you while she's beavering away. Oh, let's have a look. Let's have a look. Should we have a quick trial? It's there.
Yeah.
It's there. Perfect. Right. Pause it. I'm going to put it away.
Yep.
Okay. Yes. We've both been sweating a little bit, but this is cool. This is good because these presentations are incredible. Giuliola's joined us a number of times before, and her role is to educate. She's just fantastic. I have to tell you all how I met this amazing lady, because it still brings warmth to my heart. So I got invited to go to Moscow to go and talk about canine arthritis and how to manage it in a multimodal manner. Never done anything like it in my life. I was terrified, and this amazing lady looked after me. And since then, we've stayed in touch. I keep threatening to come out to Italy and hang out with you because I'd love to. And she invited me onto ultrasound scanning day, and I messed up my flights. And I got stuck in a Moscow airport for 24 hours because I couldn't leave because I messed up my visa. But she's absolutely fantastic. So before I let her take the realm, and she will teach you all about imaging, specifically we're doing hips and stifles today. I just want to take the opportunity to talk again about our illustrated children's book. It's a really hot topic at the moment. The Dangerous Dogs Act is being questioned, and there's a lot of activity in Parliament and with lots of groups, organisations around this topic, because we're seeing a huge rise in dog bites. And as we all know, children are often afflicted. Now, we know that there is often an underlying reason why a dog would choose to bite, and this has got to get a lot more attention. The book was written in the Moscow airport whilst I was waiting for my visa. And a very, very lovely gentleman who had got some support from CAM offered to illustrate it. It took 2 years to bring this all together. It has been, testimonials have been written by Carrie Westgate, Daniel Mills, Sarah Fisher, Sarah Heath. So it has got a lot of backing. It is available in the shop. I really want people to have it in primary schools. I want them to be in the Cubs, the Scouts, the Brownies. I want people to have this in your home, because by reading this to your child, not only you're educating yourself, but you're educating and protecting your child. Right, enough of that. Let's get on. Giliola, tell everybody about you because you're amazing.
Well, I'm a European diplomate in diagnostic imaging, but since 2008, I went back to Italy after spending my residency in UK and working in US and Europe. And since then, I started to work with musculoskeletal ultrasound, basically for pain management and also for supporting patients to make them go back to work if they are affected, or to prevent disease. This is my life. I'm traveling a lot. I love teaching, and I love especially radiology and ultrasound. So I'm really happy to be talking about one of my favorite topics today.
And just because she won't big herself up, she lectures all around the world, and she is probably the world's best musculoskeletal ultrasound. You've ultrasonographer. Have you done your course and your textbook now?
Working on that, nearly finished. I'm just working with the illustrator to finalize. So it will take still some time, but it's there.
Incredible. Right. So because we've had a little glitch, instead of it being a presentation in slide format, Giliola's had to adapt it into a movie. So she's going to, I'm going to butt out. I'm going to mute myself, and I'm just going to give her the role, the reins. That's it. So here we go. We're going to bring it up. Okay. And I'm going to mute myself, and over to you, my lady.
Thank you. Thank you very much for the kind presentation. And I'm going to discuss today why radiology is so important for hip and for Stifle. If you have kids, you know that babies are scanned by ultrasound before 3 months of age. Why we are not doing that on dog? And why we go to radiology that need sedation to scan dog for hip dysplasia? In human, we do ultrasound. Why is not working in dog? Well, we try because there's been a paper is quite aged now, and they try to check if by ultrasound we can see sign of dysplasia. Dysplasia, hip dysplasia, for the one that are not vet, is a not perfect development of the hip. Hip are very important because are fundamental for movement of the hind limb. The problem is that baby are born dysplastic. So basically, they are born dysplastic, and you can detect dysplasia when they're really, really young. Dogs are born normal, and they develop dysplasia later. So we can use ultrasound very early, but unfortunately, there is no correlation with what we will see from what will be really relevant in our patient. And this is different in human because human are born dysplastic. We can beat them, and if you had the experience and your baby will result positive on ultrasound, then you need to use a device. And when the baby will be like 5 or 6 months old, he will be cured, or the degree of dysplasia will be much less. Dog are all born normal. Normal means that there is a very nice congruency between acetabular cavity and femoral head, like in the example above, but they tend to develop some degree of changes in the hip, and this will result in less superimposition between the acetabular cavity and the femoral head. At the end of the day, means that all the pressure will be only in one point, and this will create deformity of the joint. Secondary, we will have cartilage destruction, and then osteochondrosis. So basically, we need to detect the early sign of hip dysplasia. And this is why it's very, very important to perform radiology. And I'm going to explain you why sedation is extremely important. You can see how we can perform radiograph of the hip. We need to be perfectly symmetric, certain angle in a standard view. You can imagine that in a awake patient will not be possible. Ask to the dog to lie in the back and just wait for us to take radiograph. Stay very still. This is the result. We need to have perfectly symmetric radiograph. We are lucky because we are two leg, so we can compare the right and the left. The circle that are here can explain you what are the criteria that we need to check to define if the radiograph is well positioned. So if we cut this image in two parts, the right side standard, this is right, and the left side need to be exactly the same. And why we need such a perpendicular, perfectly aligned image? Because we are going to calculate some angle, for example, Norbert angle. We're going to draw some circle because the goal, we know that the dog is not going to develop hip dysplasia, or is very, very unlikely if the head of the femur is a circle that is perfectly inserted inside the acetabular cavity. So they need to be two concentric circles. If they are like that, you know that all the pressure of the dog while will be running and jumping will be equally distributed on all the femoral head, and it's very unlikely that osteoarthrosis or pain will be developing. This is why in very young dog, depending on the breed, we go from 4.5 to 6.5 months. If you have a Great Dane, you might need to take radiograph at 6 months. If you have a Border Collie, 4.5 months probably is enough develop. And we not only were going to take Norbert angle, but we are going to obtain DAR angle. This will be the structure index. So we have a lot of criteria and objective measurement that we need to collect to have the impression and be able as much as accurate as possible if this patient will become dysplastic, because our goal is avoid for the patient to become dysplastic. And see a puppy that is 5 months old that is showing sign of dysplasia, we can really reduce dysplasia. Sometimes you need surgery or invasive procedure, but most of the time, if you have early enough with the correct muscle development, you can avoid a puppy to become dysplastic, or at least reduce dramatically the developing of the disease. Why? Because the major problem and the major reason why a patient became dysplastic are basically two. First reason is if the acetabular cavity is round, and let's say that the femoral head is triangular. So if you have misshaped and you are genetically misshaped, then you will become dysplastic. With all the year of selection, this kind of dysplasia is basically disappear. But now we have a second kind, second predisposition of dysplasia, that is laxity. For example, with this structured index, that is this drawing here, we apply a little bit of pressure on the femoral hip, and you see that the femoral head is basically outside the acetabular cavity a lot. That means that when the dog is walking, actually the hip are subluxating. And this is terrible because it will create disruption of the dorsal margin that keep the femoral head inside. So basically, what we want to see is how much laxity, how much joint laxity is present. And this caring, and might be boring for one that are not involved in this screening table, show you what are the criteria that we should consider. So, for example, the center of the femoral head on a radiograph is in the frog position, so with open leg. The head of the femur and the acetabular cavity are two concentric circles, as I show you. The angle is a weird position, but is less than 5 degrees. The distraction index, so if we put something and we try to distract the hip, you have this little value. Ortolani, so ortolani, adduction angle, and subluxation angle, these three are physical examination done in sedation. So you need anesthesia or sedation for radiograph, but you also need sedation to perform a proper physical examination. Putting all together, you can know if the patient is most likely becoming perfect or nearly perfect. There is a kind of A, B, C, D, E to the degree of hip dysplasia, where A is perfect, A or F is disaster. Basically, if all these parameters are good, this patient will be perfect, 95%. If these parameters are bad, most likely this patient will become severely dysplastic, and then this is a possible proposition for what you should do in treatment. This is a paper from Aldo Vezzoni, 2015, and I found it really helpful because you have some objective data, what you have to look for, and what is important to know in puppy to try to predict if they are going to become dysplastic or not. I'm sorry for the ones that are not vet, but probably it's easier for you look at this image, this radiographic image, instead of looking all this data and drawing. So this is very good morphology because I have perfectly concentric hip. You see here that the stabital cavity and the femoral head have a kind of an angle. They are not really perfectly concentric. It is not perfect. The angle is increasing, and in the last image, the head of the femur is outside the acetabular cavity. That's bad. This is luxation. You can imagine the degree of laxity that this patient is having. Basically, when he walk, the head of the femur are outside the acetabular cavity. That means that the limb are not attached to the pelvis. Is incredible, really. And then you see this white line. This line is drawing the dorsal acetabular margin because the hip here of the dog are positioned like the dog was walking as a human. But the dog has a 90-degree angle between the pelvis and femoral head. So the coverage of the head is actually defined by this line. And now several dots are appearing, and these dots represent the head, the center of the head of the femur. Ideally, if the center of the head of the femur is medial to this margin, that means that a lot of the femoral head is inside the acetabular cavity. So distribution of the pressure will be fantastic. If it's just, the perfect would be the point be medial to this line. If it's on the line, it's okay. Probably will not be perfect, will be nearly perfect, but still have plenty of femur covered. If the point is lateral to this line, it's not really okay because not a lot of the femur will be inside the acetabular cavity, and this is a disaster. So if you see, let's say, 6 months old or 5 months old patient with this kind of hip, you know that this will be a big problem and you need to call orthopedic surgeon and discuss what can be done. If you have this situation with physiotherapy, really you can have such big muscle that will force the hip to stay perfectly inside the acetabular cavity, and most likely you will not have problem when you will grow up. So this is why it's so important to see very early what is going to happen. About the shape of the femoral head should be a very nice round circle. But when the femoral head start to be luxated chronically, we say that it became like a mushroom shape. So you see that at the end of the day, after chronic laxity and subluxation, the acetabular cavity and the femoral head are not congruent anymore and change shape. And this is another reason why we'll have problem. Why we check all these data? Because we want to avoid these happening over time. So we start with not perfect congruent femoral head and acetabular cavity. The acetabular cavity is shallow, so there is not a lot of space of this femoral head to stay inside, and the femoral head is more triangular than round. Here, the patient will not have pain, but the distribution of the pressure will not be perfect. Going over time, things are getting worse because you start to see a certain degree of subluxation, and the femoral head will kick on the margin of the acetabular cavity, creating periosteal reaction, and even more remodeling of the acetabular cavity that now is totally flattened. And look at the femoral head, is even worse with some proliferation. And you can imagine that every step of your patient is these two bones are sliding against each other, and they are not really perfect. They are like friction, a lot of friction between them, and this is a problem. But surprisingly, the dog can have this kind of a hip and not be lame. You know why? Because if you have the cartilage still intact, you have no problem. Cartilage basically is a kind of tissue that has no pain receptor. It's covering the joint, and if the cartilage is intact, you will be fine. So we really need to save our cartilage. The last image is an end stage condition. And you can see that you don't have acetabular cavity anymore, and the femoral head is totally remodeled. But what you are looking for, and what as a vet you are really careful, is you see that subchondral bone is radiopaque. And when this subchondral bone became radiopaque, the meaning is that there is pain because cartilage is not longer helping to avoid friction. So more opaque is that, more is a sign of pain. So it's amazing how radiology is really, really important, but is not always correlated with pain unless you see sclerosis in the subchondral vein. The second joint that we are going to look, I'm going to explain a little bit the anatomy, and then we're going to discuss cases, is the joint, the Stifle joint. You see the bone, but you see there are a lot of soft tissue. So this will be the bone, fabella, the tibio-patellar ligament, alar ligament, medial collateral. These tissue are the meniscus, and then these are the cruciate ligament. The cranial and caudal cruciate ligament are really important because they are the most common surgery. Well, rupture of the cranial cruciate ligament is probably, I can avoid probably, is the most common orthopedic veterinary surgery in dog. The cranial cruciate ligament tend to rupture, and radiology is still the gold standard together with physical examination to diagnose this kind of rupture. But it's weird because this is how is the anatomy. But if we go and we are going to check how actually and what we can see on radiograph. So these images are the fusion of the radiograph with the gray image with anatomy. If we take out the anatomy, we don't really see the meniscus. Meniscus are radiolucent, so we don't see them. We don't see the cranial and caudal cruciate ligament. So how we can diagnose a disease without seeing the disease? We can see the secondary changes because when the cranial cruciate meniscus rupture, the patient will develop secondary changes. I want to show you now a patient. This is Tia, and please look how this dog is walking. She is 14 months old. She's a standard poodle. The owner, she's really, well, her life is dedicated to dogs. She works with dog. She's a dog trainer. And she realized that her dog was not working normally. She was scared. Look at here now. At a certain point, she just avoiding to put weight on her hind limb. That's really amazing because at a certain point, she's now walking only on front limb. And she realized that their dog was having some problem, especially in the morning. She was taking a lot of time to wake up, to get up. And she was a puppy. Usually puppies are really happy, shouldn't happen. And she brought her dog to a vet, and the vet say, oh, this dog has a very bad hip dysplasia. We're going to look together the radiograph. And she was not convinced, and she went to the second vet. It's terrible when you have a puppy and you have such a terrible diagnosis. So it's very common to say, I want to ask a second opinion. And to the second vet, the hip are fine and the dog is fine. But for the owner, this dog is not really fine. So these were the radiographs that the first vet obtained. And based on this radiograph, he diagnosed severe hip dysplasia. And he was thinking that the dog was walking so funny because of that. What do you think? This is a close-up view. Based on what we saw about the femoral head, the acetabular cavity, the dorsal margin that should cover more than 50% of the femoral head, what do you think? Well, they're not perfectly symmetric and congruent. You see that these are two circles that are not really perfectly aligned, but the femoral head shape is still nice, and the acetabular margin are still quite nicely around. So they are not perfect, but I don't really think that these hips are so terrible and to be able to create such a strong clinical sign. They're a little bit mushroom shape, but they're not so terrible. And this is why this dog came to me. He came to me for an ultrasound because apparently on radiograph everything was normal, but the dog was definitely not fine. He was seen by two orthopedic surgeons. They were not specialists, but they were not able to find anything abnormal because some dogs are stoic. Even if, when you palpate, they feel a little bit of pain, they will not say anything. So it's so difficult. It's such a shame that they don't speak. So this will be what I would be seeing in the medial surface of the stifle during an ultrasound. This will be the medial meniscus. This will be the medial collateral ligament, the bone surface. This will be normal. And look what I saw in the medial surface of the stifle of Tia. I was amazed because I couldn't see anything of normal anatomy. Where is the bone? Well, let's see the other one. The first one was the left side, and this is the right side. That was basically the same. A lot of thickening of soft tissue, extremely irregular bone margin, complete loss of anatomy. But how is possible that a radiograph looked normal and the ultrasound is so abnormal? And doesn't really make sense because radiology is fantastic for bone. Ultrasound is quite good for soft tissue. That means tendon and ligament. But I'm looking at the bone and is extremely abnormal on ultrasound. How is possible that is normal on X-ray? Well, we should go back to our X-ray. These were the image that we had, that we were considering the hip, but we don't have enough view of the stifle. Remember, when you are looking at a certain area, you always need to have both the limb, because every single animal is different from another one. So you should compare the right with the left, and then you need to have at least two views. So this is a craniocaudal view, but we also need the medial lateral view because it will show you the other part of the stifle. So this is the right stifle. This is the medial lateral view that was missing. And this is the craniocaudal view that we had. The best way when we are not sure what is going on is compare with normal. So this is a perfectly normal radiograph. Do you see any difference between these two images? Well, yeah, there is a radiolucent area. This is quite wide, that means quite radiopaque and uniform. There is a kind of big defect in the caudal margin of this femur. The problem is that in this view, probably is here, but it's so much more difficult to pick up. Let's see the left side. Again, we do see this big radiolucent defect. That was quite surprisingly. And again, if we compare normal and normal, we also have a radiolucent defect that we didn't see in the first set of radiograph. And when we go and we decided to take a close-up of an oblique view, we do see there is a part of the bone missing. Wow. So the first vet did a little mistake that was not taking the second view of the stifle. The reason why on physical examination was not possible to detect the defect was because the stifle were exactly symmetric. They were both diseased, but in the same way. So they were looking normal. And what should we do now? Because this is something really unusual. And we need to really understand what is going on to be able to select the best treatment for the patient. And this patient is definitely in pain. The best way to go is use secondary diagnostic imaging. In this case, this is a CT. Look how beautiful. So this is a drawing with an open stifle, and here is the articular surface of the femur that is exactly here. This will be right stifle, right and left. And this part, the medial aspect, so this part will be exactly that one. You see that there is a big piece of bone missing. Sclerosis. I told you already that sclerosing the bone means pain because there is a loss of pressure under this part of the bone that has a lot of reception for pain. And this is a big problem. So why a 15 months old dog should have these changes? Well, this is a quite well-known condition and is named osteochondrosis. What happened is that the bone doesn't develop and remain cartilage. When we and the puppy are born, the bone need to grow. So it's not fully ossified, but there are still some parts that are cartilage because they will become bone later. Somehow, some part doesn't develop to bone and remain cartilage. Cartilage is too soft. It cannot really take all the stress that a mineralized bone can take. And because of that, they will tend to break. So this is literature. We have several sources. One is PubMed. I went and I put osteochondrosis stifle because I was quite sure that this was my diagnosis. And this is a different patient, but really similar to mine. This is from Fitzpatrick, so from UK, and part of the author are from US. But this was exactly the same. This is a MRI. This is radiology. You see this huge defect, and you see that most of the medial aspect of the joint is missing. What we should do? Can we have a kind of a prosthesis because we have part of the joint missing? This is quite challenging because this is quite advanced technique. So I discussed this patient with the surgeon. This dog lives and he's in Italy. And we found out that in Spain, they have developed some kind of prosthesis for this condition. So it took us a couple of months to be able to have these processes. But luckily, at the end, we were able to have the prosthesis. So this patient went on surgery. The surgery was done by Dr. Vezzoni, a well-known orthopedic surgeon. And you can see that he basically, in the missing part of the bone, he put the prosthesis to try to create a new surface for the joint. And this is fundamental because, again, the joint should be able to be as much as congruent as possible. So all the pressure is able to be distributed normally. This is her when she was 2, so 6 months after surgery. And she is now 5. You can recognize Tia. She's a little crazy one. And even if she walk a little bit funny, sometimes she jump like a little rabbit, but she's happy. She's always running. And it's amazing that on radiograph, she has not really a severe progression of osteochondrosis. That is not always the case in this case. So this was quite an amazing diagnosis. This patient has not perfect hip, but even if they are not perfect, try to recognize what are the signs that can tell you where pain will be. So have a sclerotic subchondral bone is one of the most important signs that we should check in radiograph to define if pain could be possible. Okay, this is another lovely dog. She is 6. She is a mixed bred, and she was for the last 2 months consistently lame the left hind limb. She was better and then worse. In the morning was so much worse, and then during the day she was no bad. It's definitely time to go to the vet. Most of the time, when the lameness is subtle, the vet will tend to give you pain management or anti-inflammatory drug and see what happened, because some of the injury are self-limiting. But if lameness persists, then it's definitely time to have a orthopedic examination as early as possible, because we don't want to have our patient in pain. On physical examination, positive drawer sign. Drawer sign is a really specific physical examination test that tell you if the stifle is stable. And if it's positive, 99% of the time is because the cranial cruciate ligament are ruptured, partially or completely. The right stifle was looking absolutely normal. So let's go and see what you will see in a patient with a cranial cruciate ligament rupture or not. This is normal. We can see nice patella, the tibio patellar ligament. This radiolucent, so quite dark area, is fat because we have intracapsular but extrasynovial fat. This is synovia, where the synovial fluid is and is more opaque, so it's whiter than the fat. And this fat is fantastic on radiology because it helps us to define if there is thickening of the synovia, so synovial effusion. Synovial effusion is one of the most common signs of partial total cranial cruciate ligament rupture. So if this is normal, look at the left side, the one that is painful. What are the difference in comparison with the stifle that we just saw? Let's look at them together. First of all, the cranial cruciate ligament link the center of the femur, the articular joint of the femur, with the tibial eminence. You see these 2 points? These are the beginning and the end of the cranial cruciate ligament. First of all, we are going to check if these 2 points are still aligned. That is not the case here because the center of the joint and the eminence, they are too far away. And this is because the tibia is slide cranially. And when the tibia is able to slide cranially, this is the positive Draver sign, and it tells you that the cranial cruciate ligament is ruptured. So not always you can see such a nice cranial displacement of the tibia, but another sign that is very important is that there is increased thickness of the synovial space. Look how thin is now the radiolucent fat because we have a lot of synovial thickening of fluid. And then we start to see some remodeling of the bone that means arthrosis. So in the dream of every orthopedic surgeon, all the Stifle with cranial cruciate ligament rupture will have this amount of effusion, cranial displacement of the tibia, a little bit of arthrosis, and you can bet the best pizza in the world that this dog has a cruciate ligament rupture. No doubt about that. So the positive Draver sign with this radiographic feature, 100% sure this is a cranial cruciate rupture. And you can also see some remodeling of the patella and of the articular surface of the tibia. In this case, surgery. There are several surgery that you can do. It's still debatable what is the best, but the most common is that one that is tplo. Basically, what they do, they change the angle of the bone. In that way, you don't need the cranial cruciate ligament because rotating, creating a different angle, release completely the pressure on the cranial cruciate ligament, and the dog is not in pain. Most of the time, there will be a little bit of progression of the arthrosis that is due to the fact that this important stabilizer is break, but they will do terribly well. You see that the surgeon has to cut the bone, rotate this part, and with a plate and 6 screw, put it back together. But creating this different angle will really be fantastic for the patient. Sometimes is not so easy. And the major problem is that 70% of patients in 1 or maximum 2 years, they will break the other stifle. So be prepared if you have one dog with one tplo surgery, most likely, so 7 out of 10 will need a second surgery. And as I told you, this is the dream for orthopedic surgeon. And this is a nightmare. So this is a mix of a pit bull. Sorry for the mistake. T9 is working on my computer. He came for acute lameness in the left front limb. He was sedated for a proper orthopedic examination and radiograph. And they found that the stifle were positive for Draver sign and they were thickened. But this dog came in for front lameness. How come? And I found on physical examination abnormal stifle. Let's see what we found on radiograph of the stifle. And let's try to understand why the owner didn't realize that there were some problem. If you remember what we saw about the other patient, we see that there is very little fat because there is a tremendous effusion. This is the tibiopatellar ligament, remodeling of the fibula, remodeling of the femur, and definitely a little bit of cranial displacement of the tibia. Look at the left side, more or less the same. Why have this sign that I've told you are a sign of cranial cruciate ligament rupture, and the owner came in because the dog is lame in the front limb and not the hind limb? Well, in the dog that have really strong muscle, the stifle cannot be so clinically stable. So the owner most of the time will not realize that there is a problem. The dog might be lame for one day, but then he's happy, jumping, not a problem. Most of the time, the ruptures is bilateral. If you go for a normal orthopedic examination, not sedated, the thickness, if the chronic rupture of the cruciate ligament is chronic, the capsule became thicker, and on a awake patient, the stifle seems stable, but they are not. So you can miss a partial, complete bilateral rupture of the chronic cruciate ligament. And the problem is that over time, they will develop osteoarthrosis. And when they came lame on the front limb, because they're trying to avoid to use the hind limb, and most of the time they're putting too much pressure on the front limb, and most of the time they will develop chronic tendonitis on the supraspinatus tendon, for example, or some chronic tendonitis on the bicep tendon. So the job of the vet is not so easy. And what I tell to the owner, if you had the impression that your dog is walking a little bit funny with a hind limb, the muscle of the hind limb, they're decreasing, I think it's time to go for a vet consultation. Because if you see this problem quite early, you will avoid osteoarthrosis. That is really what we want to do. And in this patient, he had at the end second-degree supraspinatus tendinopathy on the front limb. He had chronic bilateral rupture and osteoarthrosis, but the owner was not able to detect. And sometimes also if the dog is walking and for a vaccination, maybe also the vet is not really able to understand that this dog has a bilateral problem because is bilateral and they're walking more or less in the same way on both limbs. But always remember, check the muscle of your patient, of your dog, because it will make such a big difference in the life of your patient. So what is my conclusion? Radiology is old school, but is still a fundamental step in the most common diagnosis of the hind limb of our patient. That could be hip dysplasia or chronic cruciate ligament. Of course, there are a lot of other diseases, but these one are the one that most likely your patient and your dog might have. Prevention. We need to be careful with puppy, especially big dog. Try to go and do the radiograph when they're puppy with the physical examination, and try to follow they grow the same as we do in kids. If we made them grow nicely, it's very likely to have a long life and a long pain-free life. And usually when you have a problem, you do surgery, remember that this patient need to be follow up, because maybe we put some device, and we need to see over time, over the year, what is happening to them. And the best part of our job is see a patient that was destined to be in pain, to be so happy and running as crazy. She's making the owner crazy. She never stopped running, but I think the owner is very, very happy.
Amazing. You're amazing. Yeah, there is a couple of questions. Well, one from M&A. So are you happy for me to remove that now?
Yeah, absolutely.
And then you can, oh, here we go. Go away. Here we go. Yay, you're back. So everybody was saying that your presentation is amazing.
Thank you.
Because you make it so simple. And definitely when you do the overlay, sorry, Luna's just woken up. Hey, Luna. Do you want to come up? Say hello to everybody. Come on, come up. Okay. Hello.
He's so cute.
No, the way that you overlay, that is just wonderful. Being able to put the actual 2D impression over the radiograph. I think it really, really helped people understand. I've got a question first, and then we'll go on to M&As. Over in the UK, we are encouraged to do the canine health screening and doing the hip views, as you say, the VD views and sending them in. But we get guidance with regards to the age that they're most suitable. And that tends to be more towards, full grown, so 12 months of age. Whereas you're really suggesting that it would be worth considering doing it a lot earlier. What is that? How's that work within Europe then?
Yeah, well, there is a big discussion in the South Europe or Germany about the age. They started as far as 16 weeks because to see the early phase of elbow dysplasia, the best time will be 16 weeks, but it will be too early for the hip. So that means you will need to take radiograph of the elbow and then 1.5 months later, radiograph of the hip. That means twice sedation.
Wow.
So we arrived to a compromise that usually 5.5 or 6 months of age at the best, because before this age, laxity is not strongly correlated with possible development of hip dysplasia.
Right. Okay.
But between 6 months of age and 8 months of age is when you can do most of the treatment. That could be conservative. You need to buy, for example, a tplo, or you need to go outside walking on a leash your dog for 3 hours a day. He will develop such a big muscle that the hip will stay inside. This will be one option. You can do it anyway, that is great, but let's say that you have a strong laxity. If you detect before 8 months of age, you might, for example, perform DPO. That is a kind of surgery where you rotate the hip, so you force the femur to stay inside. And you can do a lot other different conservative or surgical procedure to make your patient better. So this is why in a lot of country there is the thought that if you do X-ray a little bit early, you can do so much more. If you do radiograph at 1 year of age and you see already severe changes, it's late.
Exactly. So do you know if it's going to change with the guidance here in the UK? Because I know people that would like to do earlier. They tend to do it because they've got suspicions or it's in the line and in the family. But I've always believed that I've got to wait to be able to access our health scheme. Do you know if they can change it at all?
Well, to change a national health scheme, you need a lot of evidence and a lot of experience. For example, before, the reason why in a lot of countries they were doing a 4 months of age, because they wanted to be able to do Symphonyesis.
Yes.
There was a closure of one physis. And later, 10 years later, they knew that it was not really working. So, the very aggressive state that started 4 months, now the switch to 6.5 months, meaning that the best is still debatable. But more and more countries are starting to check early and early. So the official screening is also for us 12 months.
Yeah.
But to check the patient is 6 months. And in this 6 months time gap, you can do so much.
No, that's really interesting because, as I say, the Symphonyesis, for people that aren't listening, the center of the pelvis between those two holes that you saw called the obturator foramen, what they do, and it's around about 14 to 16 weeks, is they electrocauterize it. So they stop its growth potential, don't they? And that changes the shape of the pelvis. And I can remember speaking to a specialist and they said, well, if it does work, it's only going to work on real mild to moderate. And to be honest, are you going to pick up on mild to moderate? Because the owners that are willing to have their dogs sedated and x-rayed at such a baby stage need to have strong clinical signs to go, I'm willing to put them under sedation for you to x-ray my puppy at 3-4 months old. And that just didn't meet, you know. So you got severe signs warranting the X-ray. Oh, sorry, too severe for the Symphonyesis to work. But I think that's fascinating. That's something completely new to me, and that's massive take home. Love it. What other gems have you got, just so we know, over there in the EU? Oh, I tell you what, something we probably will never have over here in the UK is the difference between our measuring the Norberg angle and the Penn hip.
Yeah.
What would you prefer, knowing what you know?
Well, they're measuring two different things.
Mm-hmm.
The Norberg angle is measuring morphology.
Mm-hmm.
So if the congruency, if we have two nice, perfect circle, and the Penn hip will measure the laxity.
Mm.
The big problem with Penn hip is it's quite complex to do it without the operator. It's doable, but you really need to be a lot of skills.
Mm.
And this is a big problem, especially in UK, because you cannot hold the patient.
Mm.
So you need to develop special skills to be able to. But I really think that distraction index is very important, because Norberg angle, you can only do it in full-grown patient.
That's exactly it.
Because when they are puppy, the acetabular cavity is not full mineralized, so will be not relevant. While a Penn hip, you do it in a puppy to check laxity. Better if after 5.5, 6 months, so you know that there is be scientific correlation between laxity and percentage of risk to develop a dysplasia. And remember that deep dysplasia is phenotypical. That means that depending on what the puppy is doing and how quickly is growing, you can change how severe it became. So it's very important these few months how you grow your puppy.
Yeah, definitely. And that's another big take home for people that are listening, is that hip dysplasia doesn't mean it's the end of the road. It's not a definitive endpoint. Key take homes from a first opinion vet like me is weight control. Geez, come on, guys. Keep your dog lean. Think about the activities that you're doing with them. As Giliola was saying, you're looking for functional muscle mass development so that you can push that hip into the socket when that hip's dynamic, when it's moving. So, you know, there's a lot of people that will come to Holly's Elm and go, oh my God, I've just had a hip dysplasia diagnosis. Not the end of the road. We can do stuff with it. Just so people understand the difference, because we went a bit jargony there. Over in America, do they do Penn hip in the EU, or is it just America?
Oh yeah. It has been developed over there at Pennsylvania University. The distraction index is at Pennsylvania University, so they did it.
So what we have in the UK is that we're not allowed to remain in the radiography suite. So we can't be near those radio beams, basically. So we position them as best we can, but we leave the room. And that's why we don't put any pressure pulling the hip out of the socket. We place them, we extend the hips, we try and get that perfect view. But over in America, they have different rules and they have different devices where they can put traction on the hips, pulling them out of the socket to look at how much laxity is there. And that index is what they can use to show probability of dysplasia leading into osteoarthritis. So it's a very different approach. I think there might be a couple of places in the UK do it, but I know it's not very common.
Yeah, there are some elastic, there is a way to do it. You really need to be a little bit, how can I say, creative, but you can do it without being in the room. But really, you want to work. But from my point of view, is one of the most important, is a very important factor. Well, you have also ortholani test, reduction angle, and subtraction angle that are the correspond on the physical examination of Penn hips.
Right.
So basically, it's not like if you don't do that, you're blind, because you have 4 actually, because there was a marble test. You have 4 physical examination index that will help you to do so. But Penn hip is quite nice.
So that means, guys, anybody that's having their dog go in to have hip scores done, we call them hip scores.
Yeah.
The dog, whilst under sedation, should have the ortolani done. That somebody needs to be
Absolutely,
palpating.
yes.
Yeah.
Should have the ortolani, the reduction angle, and the subluxation angle done. Is like 30 seconds, but extremely important, because especially as I show you one of the paper that show you the correlation, and you have actually this table. So this is the result, put all together, look where the hip, 90% probability this dog will be good, 90% probability this dog will develop severe hip dysplasia. We definitely need to do something.
Yeah, definitely. So my other take home, which I think is really important, I'm not trying to diss anybody, but I can remember when I was a young vet, long time ago, I was at work and I'd got approached by an owner that had had their puppy's hips scanned by a mobile scanner. And it is a thing here in the UK where people will have a litter and they will have somebody come in and scan them. And then they will come in and say, you know, that they're going to be fine. I've had the hip scanned. And they might be when they're 2-3 weeks old or something along those lines. And I didn't know where to seek the information of, is it valid? Is it not valid? Is it true? I don't know what to do with this. And I can remember at the time, I didn't know who to ask, and you've answered it. So anybody that is being persuaded that scanning hips is going to be a reliable way to detect hip dysplasia, don't waste your money.
Yeah, it's a shame because it will be fantastic. And we try, you know, the author that tried to do that believed it could be possible, because why shouldn't be the same in human? But they're just too different. Human are born dysplastic, dog are born perfect, and they develop hip dysplasia. This is why, you know, you could do an ultrasound in a 12 months dog and see hip dysplasia. But it's not helpful. It's much easier and much more scientific to check on radiograph. And early ultrasound, and I love ultrasound, but it's not really the same. Definitely no.
And then if you were looking at a dog older, you would go for radiography over ultrasounding if you had to choose.
Well, radiology always came first. And the reason why, radiology show you the structure, the bone. In an older dog, you might have a bone neoplasia that will totally be missed on ultrasound. Radiology is like I open a big window. I look really far away. I cannot see the detail, but I look all the view. Ultrasound is like I'm looking by the little hole, because ultrasound look little part, and it might see better some part. Definitely can see tendon and muscle, but has not an overview of the disease. And most of the time, the change in ultrasound are due to changing in the bone structure. So you cannot jump on ultrasound without radiology. It's like physical examination first, the most important part. Second, radiology. Third, if needed, might be ultrasound.
Yeah, definitely. So I'm going to just do M&A's question, and go show yourself. I hope I've said your name right, M&A. This is a constant problem. It's a constant problem. And whether we can be kind enough to say it's cognitive dissonance, where people just don't want to see it, I think there's a very, very strong component in all of that. I'm sure that drinking a glass of wine every night, I don't want to believe that could be possibly bad for me at all. There's all of us have elements in our lives, and I try to be kind about this. In my 21 years of being a vet, I have had this happen numerous times every single week, and unfortunately you can only do what you can do. And one of the reasons CAM was created was to create a strong branded resource that you could drip feed to these people, that you could hopefully just tease them to read somebody else telling them. And quite often, you know, seeing it in print, seeing it well branded, seeing it well presented, might be enough to tick them over the edge. So that was one of the reasons CAM was created. The other thing is potentially tapping into another member of the family. I've done that before. So when I've seen an opportunity that somebody else has brought the dog in, and I will then say, actually, going to take the opportunity. Been trying to persuade your partner for a while. I also spend a lot of time saying what I see. It sounds like generation game. Say what we see, say what we see. So whenever I'm doing an examination, I will talk through what I'm doing. And when they're in the room, I will say, can you see the shape of the back? Can you see the dorsal pelvic tilting? Can you see the drop tail? And I try and get them to collect evidence. I plant seeds, drop, drop, drop. What you cannot do, learned the hard way, is tell them. Point blank, it won't work. And there is a definite psychological thing about if you tell somebody how to think, they will do the opposite. They won't do what you want. You have to give them the information to make it their decision, their observation, and then they'll come on the journey with you. It's hugely frustrating. It's really hard work. Just keep going, okay? Don't give up. And something else we hear a lot of, we have lots of people write in saying, I feel demoralized. I just feel frustrated. I see things and people can't see what I see. Well, don't get demoralized. Don't give up. I am called the rhinoceros because I haven't given up yet. It's been, I don't know how many years, 2014 I started this. Harry, who's our new director, who's been with me for a year, he's like, I don't know how you've kept up with this. I would have given up ages ago. Don't give up. Keep mental strength about it. Right, next one. Sophie, what exercise regime do you recommend in growing large breed dogs? Do you want me to answer? Do you want to answer?
It's up to you.
Go for it first, because I'm gobby.
Okay. They need to grow as lower as possible, but developing as much as possible muscle without extreme. And of course, they are puppy. We need to keep them happy. That means that, let's say if you have an explosive puppy, in my opinion, and maybe I'm sure Hannah can be more specific, but the best will be in an ideal world, I'm going on a leash with my puppy. After the muscular warm up, ideally not possible, when it will be a little bit tired, I will leave the puppy run as crazy, but not cold first thing in the morning and with other puppy, because otherwise it will be explosive. And this is when something could happen. So you need to balance between is a puppy, you need to socialize, you need to be happy, and you need to grow and be healthy. It's always a balance of you need to move because you need to have muscle, but if you jump 200 times every day, then this might be a problem. Going up the stair, surprisingly, is less a problem from a paper than going down the stair. So there's something that they can do more and other well. But activity control, that means a lot of activity, but not, for example, 200 times doing that with other puppy. This is a little bit too much stress on the joint, but a lot of other activity and a lot of playing with the head. So if they play with the head, they get tired and they are less explosive, but really happy. This would be my advice.
Totally agree. I think, I guess I'll add to that is that we really focus on joints and growth plates, and we do it at the expense of thinking about the nerves, the muscles, the tendons, the ligaments, all the dynamic support structures. So, I'm so worried about the growth plate, but I'm going to forget every other thing that's important surrounding it that protects it. And therefore, the concept that we should really restrict their activity is now flawed. We know that. Mike Farrell, Vet Lessons, go and look at his work. He's done some brilliant interviews. It's on YouTube. He explains this very, very clearly. But the idea of the 5-minute rule, building up slowly, is actually now considered very restrictive, and it's out of date. And what we really should be doing is not seeing exercise as one word. We should look at what exercise is. That's the moment they get up in the morning. That's them jumping on and off the sofa. That's them playing rag. That's them walking around the garden. There's a big thing that people all lump under exercise. And you might have somebody that walks their dog brilliantly on the lead, and they do everything great, 4-5 times a day, very controlled. But in the house, the dog is flying around the laminate floor, on and off the leather sofa, up and down the walls. They're playing tennis ball against the wall. That still isn't cool. So you've got to look at the bigger picture, and you need to put the 5-minute rule away, and you've got to think about restricting them having repetitive impact forces. So I hope that's helpful. There isn't a rule. So we have something in the UK. We have something in the UK where every vet goes, little and often, little and often. And you feel like you're some old dairy farmer from like the 90s. Little and often, little and often. And actually, that's so vague. It's so vague. So what we've come up with is the PRR. We want people to be proactive. Think about what your dog is doing. Think about how much, how often, when in the day, what surfaces, what activities, who with. Think about it. Then be reactive. Watch them. How are they doing? Are they tiring? If they're tiring, then go home. If they're showing signs of any discomfort, go home. And then be reflective. Think about it at the end of the day. Think about it the next morning. Are they a bit stiff on rising? Did they do too much the day before? So the PRR is replacing the little and often. So think about it that way. Let's see if there's any more down here. And this is where physiotherapists should be supporting. Yes, well, we do love physiotherapists massively. Really, really big component of OA development into full-blown OA care. So a high five to you, pet therapy rooms. I want to say thank you. I thank you. It makes me so happy when you do your presentations. Thank you so much for joining us. You'll see Giliola later in the year, or maybe beginning of next year now. She is one of the CAM advisors. And I'll just let you know, we now have a team of 21 global experts that support CAM. Amazing people like Giliola give up her time for free to give you guys this kind of information. What you can do in return is say thank you, but you can also tell everybody else to come and use the resource, educate themselves, and let's start getting it right so that we all can have dogs that live long and happy lives. Until next time, take care of yourselves, guys. Bye.
Bye-bye.